So we've made it through the first two parts of the presentation, and I'll finish up the last portion with a couple of cases. Sorry for the low resolution. This is just a headshot from our EMR. So this is Norma. I'm going to use her as kind of an archetype of path of the patient in terms of what many of our patients go through. It's not usually a direct path to us. It's more of a winding path, as life tends to be. And so she came to us mid-20s, young mother, otherwise healthy, but had developed a rash on her left temporal area and also a cough. Oh, this John Paul Collada took this. So John, infamous John, took this picture when he came down. He's been down a couple of times. I don't think Norma actually walked this particular path, but I put it in mainly to remind myself that the reason Norma's in the presentation is the path of the patient. And I like the picture. And so many of our patients, probably 2 out of every 3 of the patients that present on a given day, are not from our town. Our town's small, around 15,000 population, but majority of our patients come from even smaller communities, more remote areas, from homes such as this, and often arrive via public transportation, which has its own perils, as you might imagine. And often they arrive for care after having sought care elsewhere. So I think I probably had in mind that I would show up in Guatemala and there wouldn't be the kind of the fragmented care that I sometimes see in the US, but that's not the case. Care's fragmented elsewhere as well, so you can take some solace in that, I suppose. There's usually the path of the patient would include try some home remedies, not getting better, stop by a local pharmacy, because then you wouldn't have to pay for consultation if you're going to see a private physician. You can just go into the pharmacy. And pharmacy is a little bit of a misnomer in that they're not typically staffed by trained, or at least formally trained pharmacists. It's more of a kind of a small business model. And so there is a little bit of a conflict of interest in that if you show up with a URI and need time and Tylenol perhaps, that's not that profitable to the local pharmacy. So you're more likely to get a shot of some combination of NSAIDs and B vitamins and dexamethasone, or maybe a shot of ceftriaxone. So she had that path. A lot of our patients will show up with a kind of like you see in the ER or urgent care here in the US or even clinic. They'll show up with a bag or a box of multiple remedies that they've tried prior to presenting to you. But she hadn't gotten better. This was her rash. So to me, it seemed a bit vesicular, suggestive of perhaps zoster, which made me concerned about immunosuppression. And then in evaluating her cough, did a lung ultrasound, saw pleural effusion, drained the pleural effusion, and she had, this was what came out when we did the thoracentesis. So empyema, ultimately was diagnosed with TB, and we were able to get her to the TB hospital, which is in Quetzaltenango, where she got appropriate care and made a full recovery. I think at some point in her care, she also made a trip to Guatemala City because she needed decortication of kind of a rind around her lung. But a success story nonetheless, in that she eventually made it to us. We were able to alleviate some of her acute symptoms in terms of thoracentesis and, more importantly, arrive at a diagnosis and appropriate treatment. Second patient case that I wanted to share with you. This is Nicolasa. She's in her 80s. She's actually a neighbor, lives just down the hill from us. And she presented with the chief complaint of a dark spot on her foot. She attributed it to stepping on some gum at the market, and it hadn't gone away. And so I suspect she was, I mean, it's entirely feasible that stepped on gum at the market, but I don't think that was the cause of her skin lesion. It had some concerning features, as I'm sure you recognize as well, in terms of the size, irregularity, color. And she was agreeable to excision. And we did this is borrowed from, I don't think that, oh, there it is, the Twitter account, just to attribute the source, but just to show the block that we did. So posterior tibial nerve block under ultrasound guidance, which for any of you that work in the acute care setting, urgent care, ER, It's a nice block to know. This is just as an aside. Pretty low barrier to entry in terms of technical difficulty, and it'll give you nice anesthesia, pretty much the entire plantar aspect of the foot. And so we did a wide local excision, sent her biopsy to path, and came back as acral melanoma. Unfortunately, with borders which were clear of disease, both lateral and deep borders. So another success story. And neither of those patients necessarily needed an abundance of resources in terms of CAT scan, MRI, gorilla cylinder, but with the intentional choosing of certain resources such as ultrasound, and in the case of Nicholas, ultrasound, lidocaine, a scalpel, and some sutures, you can dramatically change the trajectory of her short and long-term health. She's still alive and well, to my knowledge. And so another Paul Farmer quote from the same book. Again, I'll pause and let you read it, and then we'll move on. So the title of my presentation was drawn largely from those two excerpts. The initial one, speaking of socialized to scarcity and resisting the impoverishment of aspirations. And then the second one, kind of cautionary about becoming too reasonable. And so obviously we want to provide reasonable care in the sense that we want to provide evidence-based care and care that's in line with what the patient desires. But there's a temptation, particularly in resource-limited setting, but even if you're in a resource-rich setting, there's sometimes a temptation to kind of throw our hands in the air and accept quote-unquote reasonable care as the only option. Whereas if we treat the patient as we would, say, a loved one, family member, our own mother, then often there's other options that we can consider that are possible and not necessarily quote unquote reasonable. So we've tried to, it's a struggle on a daily basis, but we try to remain unreasonable in our care for our patients in rural Guatemala. And the last few slides are just a couple of examples of visitors from VCMC. So this is Alicia Yee. When she was a resident, she came down. That's her doing a lac repair of a pediatric patient who'd been involved in a mototaxi accident, of which there aren't any shortages of mototaxis nor accidents. And then this is very own Dr. Steller. She spent a significant amount of time with us as a global health fellow, and that's her working with Dina on our pericardiocentesis model. It's a big needle. But just a sampling of what, if you were to visit, what you may be involved with in terms of teaching and direct patient care. Oh, and to further entice you, this is now the inside of the rooftop studio apartment. I think it's pretty nice. Probably has the best view on the property. Once you go outside that door, it leads to a private courtyard, and you can see the mountains. And then that's kind of the almost panoramic view from sleeping area.